Hello, welcome to this session of the International Psychogeriatric Association. I am Dilip Jeste. I am Senior Associate Dean for Healthy Aging and Professor of Psychiatry and Neurosciences at University of California, San Diego. I'm going to talk about positive psychogeriatrics. At the outset, I want to say that I have no financial relationship with the pharmaceutical industry. In my talk, I will be focusing on 5 different areas. I will start with what is positive psychogeriatrics. Next, I will discuss positive and negative enablers of healthy aging. Then will come wisdom, followed by positive psychogeriatric interventions. And finally, I will conclude with strategies for flourishing. What is aging? We read all these ads about cures or ways to prevent aging. However, aging is not a disease like cancer or heart disease to be cured or prevented. Aging is an active and ongoing life process that begins at conception. It doesn't begin at age 65, it begins at conception and is associated with a dynamic balance between growth and development on one hand and degeneration and decline on the other hand. Often, people think about aging as inevitably associated with degeneration and decline. That's not entirely true. There is growth and development that also goes on with aging. Why do we need positive psychogeriatrics? There is growing need for healthcare services because the population is rising all over the world, and especially the number of people in the older categories. The fastest growing segment of the population is that of people over age 85. They need considerable amount of healthcare services, and yet the availability of clinicians with specialization in geriatrics is declining. So we will have to focus more and more on prevention of diseases and disabilities in aging. Prevention includes things like lifestyle changes, improving the activity level, reducing sedentary behavior, improving nutritious diet, stopping smoking, sleep hygiene. These are all behaviors. And who are experts in behavior modification? Psychiatrists, psychologists, mental health, nurses, social workers. So it is important that we as psychogeriatricians focus on behavior modification. The current focus of treatment right now is, for example, reducing depression. But we should also increase happiness with life. So not just going from -5 to 0, but going from 0 to +5. How do we define positive psychogeriatrics? I define it as science and practice of geriatric psychiatry that focuses on study and promotion of mental health and mental well-being through enhancement of positive psychosocial factors that are relevant to mental or physical illnesses. So you will see that the goal is not just treatment of illnesses, but improvement of mental health and overall well-being. And this would apply to people not only with mental illnesses, but also those with physical illnesses. At the University of California, San Diego, we have been conducting a study for the last 10 years called SAGE study, Successful Aging Evaluation. This is a longitudinal study of all three domains of aging, physical, cognitive, and psychosocial, in a community-based sample which was selected using random digit dialing. The sample includes over 2,000 home phone users in San Diego across the entire adult lifespan from age 21 through 100 plus. We start with a phone interview, then we send them a survey, either mail it or these days we send it by email, and then we also collect saliva sample for genomic analysis. We have a unique focus on positive traits such as resilience, optimism, compassion, and wisdom. So we not only study diseases and disabilities, but also study positive psychosocial factors. So this is a slide that shows changes in physical health and mental health across a lifespan from age 20 to 100. Physical health, as we can expect, is at the best in the 20s and 30s, then slowly starts declining, and the decline accelerates after age 60. So by the time people are in their 90s, most people have physical illnesses and disabilities. What happened to mental health with age? Well, it goes exactly in the opposite direction. The 20s and 30s, which are called the fountain of youth, are also the fountain of anxiety, depression, stress. The good news is that mental health starts improving after that age, and people in the 80s are happier than those in the 20s. It is not that they have less stresses, not at all, but they react to the stresses, they handle the stresses much better than the younger ones do. So that is what I call paradox of aging. Physical health declines, but the mental well-being improves. This happens even in serious mental illnesses like schizophrenia. In schizophrenia, physical health declines with age even faster than in the general population. There is accelerated biological aging, and unfortunately, people with schizophrenia often die young from diseases that normally wouldn't occur until much later. But even in this population, mental health improves with aging. The psychotic symptoms go down, negative symptoms go down, subjective quality of life improves, people become more adherent to medication, rates of smoking go down. So that paradox of aging we see in schizophrenia and other serious mental illnesses also. So this is a slide showing the data on physical versus mental well-being in people with schizophrenia. The red line shows physical well-being, whereas the blue line shows mental well-being. And this is from age 40 to 90. So what you see again here is a decline in physical health accompanied by improvement in mental well-being. There's something that Ellen Sachs called wellness within illness. Even people with serious mental illness like schizophrenia or serious physical illness like AIDS and cancer do have pockets of wellness and happiness. Even in this population, well-being increases with aging. Often, the explanation for that is given is what is called healthy survivor bias. The sickest people die young and only the healthy people are left in later life. And there is no question that that is true to some extent. However, we have found that when you follow people longitudinally, they become happier and their well-being improves. A sizable minority of the patients with serious illnesses have scores of well-being in the normative range. And the well-being is correlated with levels of resilience, optimism, and other positive traits, but not with things like sex or race, education, or even illness-related factors like duration of illness. Now I want to switch to positive and negative enablers of healthy aging. In other words, what are the risk factors for diseases of aging, and also what are the protective factors for diseases of aging. The three most important protective factors on which there are lots of data are resilience, optimism, and social engagement. Numerous studies have shown that in physically ill patients, resilience is associated with medically desirable behaviors. These are the things we want our patients to have so they will get better faster. Ability to take care of themselves, self-care, treatment adherence, more physical activity on a regular basis, and better health, including less pain. Resilience is associated with such behavior and also results in greater longevity. Optimism, there is a meta-analysis with 83 studies of optimism from across the world, different age groups, different countries, different ethnic and racial groups. The investigators found that optimism was associated with better cardiovascular outcomes, better physiological markers such as immune function, better outcomes in people with cancer, and markedly reduced mortality. And all of these associations were highly significant, p less than 0.001. And these associations stood even after controlling for factors such as treatment adherence or healthcare access. For social engagement, there is even greater literature. 148 studies with a total sample size of greater than 300,000. Again, these are people across the world with different diseases or no diseases across age groups. The meta-analysis showed that there was 50% increased likelihood of survival among people who were socially engaged compared to those who were not. So, in other words, there is tons of data now showing that resilience, optimism, and social engagement are good not only for mental health, but also for physical health and longevity. This is one study from the Netherlands. This is a study of people over the age of 65 who did not have heart disease or cancer to start with. And these people were followed over a period of 15 years. The investigators looked at the level of optimism at baseline. So what this slide shows is three groups of people. The top line shows the people with the highest level of optimism. The bottom line are the most pessimistic people, and then others in between. The investigators found that people who are most optimistic live significantly longer, on an average 8 years longer than the most pessimistic people. And this difference was significant even after controlling for things like physical exercise, smoking, statin, and what have you. There are also social and environmental factors that can affect well-being, health, and longevity. These include family dynamics during childhood, family support throughout life, social network and social support, and cultural attitudes and biases. So environment, behavior, the family level, community level, they all impact health, well-being, and longevity. These are all positive factors. Among the negative factors, the risk factor, a very important one is loneliness and social isolation. Loneliness and social isolation, they are related, but not quite same. Loneliness refers to the subjective feeling of being alone, isolated, and distressed, whereas social isolation is an objective lack of social relationships. So one may be happy while alone, Somebody living in a cave can be happy. On the other hand, one may feel lonely in a crowd. College students living in a dorm surrounded by several hundred other students, they may feel very lonely. So loneliness and social isolation, they are related but different. Loneliness has been called a silent killer. There has been kind of a pandemic of loneliness across the world over the last 2 decades. Loneliness has been shown to increase the odds of mortality by 30%. It is as dangerous to health as smoking 15 cigarettes a day and more dangerous than mild to moderate obesity. In the US, according to the Government Agency for Healthcare Research and Quality, 162,000 deaths per year are attributable to loneliness. That is more than the number of deaths secondary to lung cancer or stroke. And loneliness affects not only health, but it also has financial implications and business implications. In the UK, the businesses found that they were losing billions of pounds because of loneliness of the workers. So in 2018, the Prime Minister of UK appointed a new Minister of Loneliness. Why is loneliness so dangerous? Because it is a risk factor and a major risk factor for heart disease, diabetes, obesity, major depression with suicide, opioid use, alcohol use, generalized and other anxiety disorders, and Alzheimer's disease and other dementia. A number of longitudinal prospective studies have shown that people who are lonely at baseline are at a higher risk of developing these diseases years later, and that what contributes to increased mortality associated with loneliness. The risk factors for loneliness, including specific age groups like 20s, 50s, and 80s, being single or having stressful marital relationship, serious mental illnesses like schizophrenia, depression, physical illnesses, chronic work stress or chronic social stress, or socioeconomically disadvantaged groups such as immigrants, LGBTQ, racial ethnic minorities. And the reason for their loneliness is not biological, but it seems more environmental. So I've been talking about both positive factors like resilience, optimism, social engagement, and negative ones like loneliness and social isolation. One of the most important positive factors is wisdom. And this is an area that we have been focusing at UC San Diego for the past 15 years. Wisdom is a religious and philosophical concept. It is there in practically all the religions of the world, all the philosophies of the world. However, empirical research on wisdom did not begin until 1970s. In the mid-70s, researchers at Max Planck Institute in Berlin and those at University of Southern California in Los Angeles began to study wisdom. And since then, the number of papers on wisdom has been growing exponentially. In the last decade, there were 2,000 peer-reviewed papers on PubMed that were focused on wisdom. So what is wisdom? Wisdom is a personality trait. It is a complex trait with multiple components. And I will talk about those components very soon. Wisdom is not same as intelligence. Intelligence is necessary but not sufficient for wisdom. Wisdom is associated with greater well-being, greater happiness, more life satisfaction, better general health. So I mentioned about specific components of wisdom. So what are those components? An important component is self-reflection. This is the ability to look inwards, try to understand our own behavior, thinking, feelings. So instead of blaming others, we try to find out if we did something wrong so we can do better. Another very important component of wisdom is compassion. It is empathy and compassion. Empathy means understanding and sharing emotion, whereas compassion means behaving, helping others. And compassion includes compassion toward oneself as well as compassion toward other people. Emotional regulation. There is control over emotion, not getting too upset, too angry, or too happy, but having some control with contentedness. Then comes acceptance of uncertainty and diversity of perspectives. Realizing that there are different facets to truth and that different people may have different conceptualization. And at the same time, one cannot sit on the fence being uncertain. You have to be decisive when you need to be. And finally, spirituality. Spirituality is different from religiosity. Spirituality means feeling constantly connected to yourself, to someone else, or to the God, or the spirit, or the universe, consciousness, whatever it is. So these are the components of wisdom based on the literature as well as based on some studies of the ancient scripture. So it looks like the basic concept of wisdom hasn't really changed across centuries or across geographic periods. The good news for loneliness is that loneliness and wisdom go in opposite direction. We have published several papers that show a strong inverse correlation between wisdom and loneliness. So on this slide, the horizontal x-axis represents wisdom, whereas the vertical axis, y-axis represents loneliness. So what you see is that people who have high levels of wisdom are not lonely and vice versa. Wisdom, as I said, is a personality trait, and the traits are typically based in the brain to some extent. Most traits are about 50% inherited, which means that 50% determined by environment and behavior. So wisdom is based in the brain. Where in the brain is it based? Thinking that it has different components: self-reflection, empathy, compassion, emotional regulation, and so on. The two main areas of the brain that are involved in wisdom are prefrontal cortex, especially the dorsolateral prefrontal cortex, ventromedial prefrontal cortex, and anterior cingulate, and limbic striatum or amygdala. Number of studies have shown that these regions are critically involved for individual components of wisdom and very likely for the wisdom as a whole. How do you measure wisdom? A number of scales are available for measuring wisdom. We developed a scale that is called San Diego Wisdom Scale. It has 24 items, each to be rated on a 1 to 5 scale. So there are 24 different statements, and you have to say you strongly disagree, to disagree, neutral, agree, and strongly agree. And then you get a score for the total score as well as for each component of wisdom. We have shown it to have good to excellent psychometric properties. Examples of items include: it is important that I understand the reasons for my action. So that is looking at self-reflection. Another is I have trouble thinking clearly when I'm upset. So that is opposite of emotional regulation. Does wisdom increase with aging? There are no longitudinal studies in the literature yet, but number of cross-sectional studies suggest that wisdom may be increasing in later life. Studies have shown that older people have greater control of emotions than younger ones. Older people tend to be more positive, that is, they favor positive emotions and memory. They make better decisions that require experience and experience comes with age. They have more empathy, compassion, and other prosocial behaviors. And they also have greater self-reflection or insight. And these are all components of wisdom. So one would think that wisdom may increase with aging. Of course, this doesn't happen in everybody. There are some old people who are very unwise, and you can get some young people who are quite wise. But by and large, age brings with it experience, and that experience can make a person wiser. How is it possible that anything can improve with age? Anything in the brain can improve with age? Because we usually think about aging as being associated with decline in brain functioning. Well, there is decline in brain functioning, but there is also there are areas of improvement. For example, in people who keep themselves active, this is an important if. In people who keep themselves active physically, socially, and psychologically, there is greater recruitment and more efficient utilization of neuronal network. And this may compensate for aging-related cognitive decline. There is formation of new synapses and possibly even some neurons in selected regions of the brain, like the hippocampal gyrus like the dentate gyrus of the hippocampus, with physical or psychosocial stimulation, and that is what one may call neuropsychoplasticity of aging. Studies have shown, studies with functional MRI, that there is reduced dopaminergic activity in reward circuitry involving limbic striatum, which may be responsible for emotional regulation in late life. Similarly, diminished amygdala activation with negative or stressful emotional stimuli, regret or fear, that may be responsible for positivity in later life. Importantly, there is something called grandmother hypothesis of wisdom. Studies in bottlenose dolphins, killer whales, Seychelles warblers, which is a species of bird, and humans have shown that when grandmother GM helps her adult daughter D in raising her children, the daughter D lives longer, is happier, and produces more children than the grandma did. And there is greater happiness, health, and longevity in all three generations. These are papers published in the topmost journals in science, such as Nature and Science. Some of my colleagues at UCSD have reported grandparent genes, variants of ApoE and CD33 that are associated with better functioning heart and brain in later life. So we talked about positive enablers as well as negative risk factors. But how can we use this information for developing interventions? Number of studies have shown that physical and mental activities are critical for improving brain function. So these include not only physical exercise, but also things like Tai Chi, yoga, meditation, mindfulness, and so on. Intergenerational activities are very helpful for both generations. There's a study called Experience Core, in which trained older adults volunteers served for at least 15 hours a week in public elementary schools as mentors and tutors to enhance children's literacy development and behavior management skills. The outcome was improvement in children's grades and happiness, but also enhancement of seniors' mental and physical health, and even in biomarkers of stress and aging in blood and urine, and even hippocampal volume on brain MRI. What this means is that wise parenting, and especially wise grandparenting, can be helpful for all the generations. Technology is becoming increasingly important even for older people. So this slide shows a wearable device, which can be like a Fitbit, kiosk where you'll have your blood pressure measured, use of video games, telemedicine, and even robots. Video games, which are often problematic for younger people, actually they can be helpful for older people when they involve some cognitive activity. And this is true not just for healthy people, but also for people with mental illnesses, including serious mental illnesses. Our group has done a number of studies and developed interventions based on psychosocial aspects. These include cognitive behavior therapy, social skills training, functional adaptation skills training, vocational rehabilitation. The functional adaptation skills training was translated into Spanish for older people called PEDAL, and mobile interventions. These interventions not only improve functioning, but they also can have effect on the brain. This was a study done by researchers at Harvard and Pittsburgh. They showed that cognition enhancement therapy in people with schizophrenia increase gray matter density in specific regions of the parietal lobe that could be seen on MRI. Mobile intervention. Increasingly, they are becoming more common. During this COVID era, when physical distancing has made it difficult for people to interact, telemedicine has grown a lot. And increasingly, I believe that there will be intervention, even in psychiatry and psychology and social work and nursing, that will involve technology. Our studies have shown that programmed text messaging 3 times a day for 12 weeks can promote illness self-management and healthy lifestyle. Even in people with mental illnesses like schizophrenia, we found minimal rate of dropout, no broken devices. Their adherence was similar to that in non-psychiatric samples, high participant satisfaction, and they suggest that use of technology is feasible and acceptable. Of course, we have to train our patient in the youth, and that will take some time. But with training, people with mental illnesses can use technology as well as people without mental illnesses. And these kind of mobile interventions are going to be increasingly important in future because they can deliver care outside of the clinic setting, reducing the need for transportation. They will reduce or extend face-to-face intervention, increasing access. They will increase recall of health beneficial action. For example, getting reminded about taking your medication or going out for a walk. And this will compensate for forgetting. And identifying actionable within individual patterns of symptoms, personalizing care. For example, somebody who needs physical activity and is told to walk twice a day can get a reminder in the morning if the person hasn't already started walking. So there are multiple benefits for this mobile intervention for improving lifestyle of the population in general. Another particular use is what are called just-in-time intervention. For example, if you are tracing somebody's symptoms of depression continuously through smartphones, you can catch the person when the person's sleep deteriorates, eating goes down, physical activity goes down. That's the time you can bring the person in or call him or her to find out if these are early signs of worsening of depression. So you can thwart suicidal behavior before it occurs. So these are the implications from how we treat people, including people with various illnesses and mental illnesses. So right now, what do? We diagnose a disease and then we prescribe medication. We need to go beyond that. What we need to do is, of course, we have to prescribe medication when they are warranted. But we should also prescribe, say, long walk 5 times a week. Use of technology like Fitbit, which will help you see if you did enough activity, and if not, you can still do it during the rest of the day. Increase resilience. There are interventions that can improve resilience, and I will talk about these. Healthy diet. Work or even volunteering, so long as they are rewarding. sleep hygiene. As I said, playing video games for older people can improve their brain function. So these are the interventions that are available that should be used for people with and without illnesses. Now I want to switch to even bigger area that obviously we need to treat illnesses and bring them under control. But we should go beyond that. Our goal should not be merely to reduce depression. Our goal should be to increase happiness. And so these are strategies for flourishing, not just surviving, but thriving and flourishing. So here we come back to wisdom. Improving self-reflection, emotional regulation, empathy, compassion, so on and so forth. So can wisdom really be enhanced? The answer is yes. Most traits, as I mentioned, are only partially inherited, about 50%. And even gene expression can be influenced by environmental and behavioral factors, as shown in epigenetics. Wisdom may increase with aging and experience, as I mentioned. Wisdom can increase with learning, but wisdom is reduced with specific brain trauma or specific disease, which means that wisdom is modifiable. Other possible means of enhancing wisdom would be psychosocial, behavioral. In future, there would be pharmacological, biological, and technological means of doing those. Right now, those means are not quite there, but in future they will be. So right now, we will be focusing more on psychosocial and behavioral intervention. Can we increase things like emotional regulation, empathy, compassion, and spirituality through psychosocial behavioral intervention? Actually, the answer is yes. We recently published a study. My younger colleague, Ellen Lee, was the first author of this paper, which we published in JAMA Psychiatry just a few months ago. We did a meta-analysis of all the randomized controlled trials for enhancing specific components of wisdom. We found 57 randomized controlled trials to enhance empathy or compassion, or emotional regulation, or spirituality. And these trials included people with mental illnesses, some people with physical illnesses, and some were people just from the general community. Nearly half of this study, 47%, reported significant increase in the level of the specific component of wisdom with moderate to large effect sizes. What it means is that we can improve these components in at least some people. May not be possible in everybody, but in nearly half of the people, it was possible. We also did a study that was published, again, just a few months ago. This was in International Psychogeriatrics. This is the Journal of the International Psychogeriatric Association. So this was a study of an intervention to enhance resilience. We had 1 month control condition, 1 month intervention period, and 3 months of follow-up. This study was done in 5 retirement communities in 3 states in the US. We used a manualized behavioral intervention, which was administered by the facility staff. It was not administered by researchers. And it included things like savoring, engagement in value-based activities, things that are important to you, like work in the community, keeping a gratitude diary in which you write a couple of things that made you feel grateful to others, and homework that you consciously practice a couple of random acts of kindness every day. We found that there is significant improvement in resilience, significant improvement in wisdom using the scale that I described, San Diego Wisdom Scale, and significant reduction in perceived stress. And a small pilot sub-study showed that the reduction in loneliness was mediated by increase in compassion. So if we increase compassion, which is a component of wisdom, we can reduce loneliness. So how do we translate that into our everyday behavior? And this is something that will relate to us as individuals, but also for our patients. So practical wisdom means forming a habit of making wise decisions in everyday life. Not necessarily the major decision, but even smaller decisions. Like when you have a fight with your friend, how do you resolve that? So these wise decisions involve self-reflection, emotional regulation with positivity, empathy, compassion, decisiveness amid uncertainty, and spirituality, all components of wisdom. And let me just give you some examples of this. How can we use compassion to reduce loneliness? So one thing is practicing what one may call random acts of kindness to others. Just try to help somebody, some stranger that you're not planning to. Equally important is self-compassion. Often people who are compassionate toward others are very harsh on themselves. That doesn't help. You need some self-kindness, which is different from narcissism. You need to have some self-criticism, but also it should be balanced with self-kindness. And then there should be mindfulness, sense of common humanity. When you make a mistake, you're not alone. Everybody makes mistakes. So what I'm talking about is positive psychiatry. I talked about positive psychogeriatrics. How do we practice that in our everyday practice? And this is something that will apply to primary care clinicians. We are all very busy. We have a very short time to see patients, and much of the time is spent in diagnosing the condition and prescribing the medication. But we should do our best to also assess their well-being. We only ask about their weaknesses and risk factors. We should ask about what are their strengths. What are the things they like about themselves? What are the stresses in life? How is their lifestyle? And this can be done by having the patients and their caregivers filling some form in the waiting room or at home prior to the visit. This will help us identify treatment target and plan intervention accordingly. We must include caregivers in this discussion. Use of technology, as I said, is going to become increasingly common, and patients often need training in the use of technology. It is also important to make the communities age-friendly. And AARP, AARP is involved in sponsoring these sessions, and I'm just grateful to AARP for that reason. The World Health Organization and AARP have an exciting initiative that's going on for several years now that is called Age-Friendly Community, which involves collaboration between governments, businesses, academics, and community. And the focus is on healthcare, lifestyle, technology, intergenerational and volunteering activities, plus education. So it means providing opportunities for older people to learn new things, to get jobs, acquire leadership position in the community. And this is something all of us can do to help our community become more age-friendly. Just talking about wisdom, and people often think about wisdom as religious, philosophical, but it is a scientific concept. And for those of us who are involved in medicine and healthcare, wisdom has a considerable relevance for medicine and healthcare. For example, if you look at the components of wisdom, such as emotional regulation and empathy, compassion, these have relevance to people with illnesses. A number of cases have been reported in the literature when, following a brain injury, the person could not control the emotion. The person lost empathy and compassion. Similarly, some of you are familiar with what is called FTD, frontotemporal dementia. This is a type of dementia that occurs earlier in life than Alzheimer's. Usually it occurs in the 50s. And this is not associated with memory loss till much later. The main problem is change in behavior. And as the name suggests, frontotemporal dementia. The part of the brain that is damaged is the anterior half of the brain, that is frontal lobe and anterior part of the temporal lobe. The main symptoms of the behavioral variant of FTD are personality change. People lose their emotional regulation. They become antisocial, apathetic, and their overall behavior looks quite unwise. So clearly these are the people who need intervention, who need help, improve those components of wisdom. Autism spectrum disorder is associated with deficit of cognitive empathy. People with autism are very kind people. However, they have difficulty understanding someone else's emotion. So that cognitive empathy can be improved through intervention. Antisocial personality disorders are of course associated with lack of compassion. Studies have used spirituality, enhancement of spirituality for people with physical illnesses, especially cancer. And spirituality is now a formal component of palliative and hospice care. In future, I think there will be pharmacological, biological, such as transcranial magnetic stimulation or deep brain stimulation, and technological, such as wise robots as coaches intervention. So, to summarize my presentation, so there are 5 points that I want to stress. First is that aging is not all gloom and doom. Aging is associated with decline in physical function, and in later life also some decline in cognitive function. However, aging tends to be associated with improved mental well-being. Older people can, and many of them do have, improved happiness, contentedness. They can handle stress in a much more mature fashion. So we can learn a lot from older people. And older people can be great mentors for the youth. Second point is that resilience and social engagement can improve health while loneliness worsens it. And there are numerous studies have shown that resilience, optimism, and social engagement are associated with better well-being, greater happiness, better physical health, and even greater longevity. In contrast, loneliness and social isolation are associated with greater depression, high risk of dementia, heart disease, stroke, and shorter longevity. Wisdom is a personality trait. It's a complex personality trait. It has different components such as empathy and compassion, emotional regulation with positivity, self-reflection, accepting uncertainty and diversity of perspectives, and yet being decisive when there is a need, and spirituality. Wisdom is much more than intelligence because it improves individual health as well as societal well-being. As I mentioned, the grandmother hypothesis of wisdom shows that when grandparents are involved in raising grandchildren, all 3 generations, the grandparents, their children, and the grandchildren, all 3 generations become happier and healthier. Psychosocial interventions are there. Psychosocial interventions are useful not only for improving mental health, but they also have biological effects. As I showed you, that this cognition enhancement therapy in people with schizophrenia can increase gray matter in parts of the parietal lobe on MRI. Similarly, meditation, mindfulness have been shown to increase white matter integrity on brain imaging, as well as reduce the level of inflammation. And these interventions are useful in older people too. And finally, what I've talked about is this concept of positive psychogeriatrics, that let us not look at aging as all negative. It is not. There are so many positive things that also occur with aging. We should embrace them. Older people are a great resource to the society and to the younger generation. And this is important for us to transmit to our patients and the caregivers. Our attitude needs to change, and then we will change their attitude. And positive attitude, optimism, along with resilience, social engagement, and wisdom can improve health. Of course, there is worsening of physical health and cognitive decline that occurs in later life. So we have to be aware of that. And not all older people will do well. Nonetheless, many of them will. And what we have to do is having a positive but realistic approach and help people improve their healthy lifestyle and positive attitude. Thank you for your attention, and I wish you all the best in your practice or research or training.